Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman. On this show, you'll receive powerful insights and resources for rural surgeons. I'm a general surgeon in Northwest Indiana, and this show is tailored around the nuts and bolts of rural general surgery practice. But you'll find topics ranging from practical surgical tips to a host of others, including rural lifestyle, finance, training, practice models, and more. We'll have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. Whether you're a surgeon, other specialist, or primary care, or simply someone interested in healthcare for rural America, I'm glad you're here. Now let's get into the show. Welcome back to another episode of the Rural American Surgeon. I'm here with one of my greatest mentors, Eugene Shively from Campbellsville, Kentucky. I met him as a fourth-year medical student when I was at University of Cincinnati, and I went and told the chair of the Department of Surgery that I wanted to be a rural surgeon. He said, if you want to be a rural surgeon, you have to rotate with Eugene Shively, essentially the godfather of rural surgery. And so, Dr. Shively, thank you so much for coming on to the show.
You're welcome.
So we've got a lot to talk about today. We may have to bring you back as another guest another day, but there's so many stories. I'd just like to start with an introduction of you. So tell us a little bit, just in brief, about your training and what your career has been like throughout the years.
Well, I graduated medical school in 1970 from the University of Louisville. I did a rotating internship at the University of Cincinnati. I wasn't exactly sure what I wanted to do. And then I was in the Air Force as a flight surgeon in a C-130 outfit for 2 years, and then came back to the University of Louisville, where I graduated from medical school and did a surgery residency under Dr. Hiram Polk.
Yeah, and then you came essentially very close to your hometown, right? And then practiced.
This is my hometown.
So Campbellsville was your hometown, and then practiced there for how many years?
Well, I've been here 46 years, and I stopped doing surgery just before COVID.
So you're how old now?
I'm 80 years old.
80, right. And so now we're recording in 24, so just before the pandemic in 2020 then. So I want to talk about the rotating internship in Cincinnati. So you've told me before that rotating internship is one of the best things that made you a well-rounded doctor. And then you've told me some crazy things. I want you to tell me the parathyroid story and maybe the trach story.
Well, the University of Cincinnati, Dr. Altemeyer was the chairman, and that was the traditional surgery program. You worked there very hard, many times every other night. It was a 6-year program. You got certified in general and thoracic surgery. You were not allowed to be married. And at the end of your residency, you were invited to debutante balls. Dr. Altemeyer had a tradition of that he scrubbed on every parathyroid. And we had a parathyroid adenoma. And the chief resident started the case. He dissected out the parathyroid adenoma, and then Dr. Altemeyer scrubbed in. The chief resident covered the thyroid back over the adenoma, and he said, Dr. Altemeyer, we're having a little trouble finding this parathyroid adenoma. Can you please help me? So he pulled it up. And he said, here it is, Henry. And Henry said, thank you so much. And Dr. Altemeyer scrubbed out. And that was the end of the case after closure.
That's fantastic. It just sounds like a totally different world.
It was a totally different world. It was a male-dominated, very rigorous, demanding program that required tremendous amount of persistence and resilience. But I enjoyed my internship there. And I'm glad I did a rotating internship because I think it taught me a lot, taught me to be eventually a better surgeon. I was understood medicine better, and even OBGYN and pediatrics.
So a question I like to ask everyone early in the show is, why is rural surgery special to you?
Well, I came back to Louisville because I wanted to get back closer to home, and my parents were getting older. I had the option of staying in the Air Force and going to down to Austin and doing a residency, but I decided to come home, and I wanted to come home and practice where I was raised. And I felt that there was a huge need in rural America. At that time, the family doctors did a lot of surgery. There was only one surgeon in Campbellsville, and there were no other specialties. And some of the family doctors did quite a bit of surgery. They would do cholecystectomies, hysterectomies, appendix, and they also did some orthopedics, a closed reduction predominantly. The general surgeons surrounding Campbellsville were real general surgeons. There were 3 general surgeons in Lebanon, Kentucky, which was 20 miles away. They did fractured hips, all types of surgery. And the same way in 2 other towns surrounding the community. There was one in Greensburg who did all types of general surgery, and they all did OBGYN. They didn't always do OB deliveries, but they'd do C-sections if the family doctors needed them to do a C-section. And the same way in Columbia, Kentucky, there was a surgeon who did all that. They didn't routinely do thoracic surgery, but if they had a patient that needed a chest tube or thoracentesis, they would do it. And rarely, I know one of the surgeons who did some neurosurgery, drained epidural hematoma one time because it was an emergency and they couldn't transport the patient. So they provided a phenomenal amount of care, and I wanted to be involved in that. And I decided that family practices were probably not the best way, because I knew eventually the family doctors would not continue to do surgery, and surgery was exciting and very rewarding.
Yeah. So let's move to the how I do it section of the show. We've decided ahead of time, and I should probably say that we're here in Campbellsville, and I'm actually down visiting to record this podcast and also just to spend some time. And we are in your cabin. The cabin is really cool. Tell us the story about the cabin.
Well, when I first moved back, there was a friend of mine who liked to tear down log cabins and number them and sell them. And he talked me into buying these 2 log cabins. And one of them is now about 200 years old. The other one's approximately 150 years old. But after I bought them from him in August, he said, by the way, you got to put these cabins back up. If you leave them on the ground, they'll rot. So I got some college students to start doing that, but they didn't know what they were doing. So I hired a guy who just lived down the road, and he had put up assembled log cabins before. And so he helped them do that. And then the next summer, we put this A-frame between the 2. Now, not knowing anything about construction, I didn't really think about that one of the cabins is 3 foot higher than the other one, and none of them was square. And so this the room in between took a special carpenter, and took him about 4 months just to complete this room. And we have stone in here that's from an old slave fence, and then we have a stone that my wife found a guy that was hauling a bunch of rock, and he asked him what he was going to do with it, and he wasn't sure, and so he decided that we would buy that. And some of the stuff on the outside It's very, very heavy. The guys who put that up, they would have to lay the mortar and have to stay there for about at least 5 minutes, and then they put the stone on top of it. It was extremely difficult work, but it turned out remarkable.
Yeah, it's really cool. So essentially 2 cabins, one's 200 years old, one's 150 years old, and then this A-frame built connecting the whole thing. And we're sitting in the atrium, and then he's got it decked out with all kinds of animals, some of which are your son-in-laws, and then you've got a moose that you say is older than you.
Yes, this moose was killed out in Wyoming, actually during World War II, and you can see the moose there. And then there are 2 mule deer, the Kentucky deer, not mule deer, that came from out west. They were also killed during World War II.
So anyway, that's where we're coming from, and why we're in the unique setting, not like I usually am. But let's move on then to the How I Do It segment. And what we've decided to talk about is something that's not done very commonly anymore, but probably will be interesting to my audience, which is essentially just me. So that's fine. And that's an exploration of the common bile duct. And I do also an exploration of the common bile duct, but a little bit differently. And so that might be something we can talk about a little bit. So first off, who's the patient that needs an exploration of the common bile duct?
Well, one that has stones in the common bile duct. And when I started off, I started doing routine cholangiography. Even when we were doing open, I started doing laparoscopic cholecystectomies in 1990. And there's a story to that also. And when we found common duct stones, we would usually open, explore the common duct, and put a T-tube in. And, everybody thinks that's a sin to have to do that now, but it's actually a good operation, and the patients do quite well. And there's nothing wrong with opening, exploring the common duct. You can take care of most of the problems that way, get the stones out, put a T-tube in. And one of the advantages of doing that, if you have a patient with multiple stones and you leave a stone in, about a month to 6 weeks later, you can scope the patient through the T-tube track and then do the choledocoscopy. You can take the stone out. That's something that most people don't know about. Choledocoscopy is not hard to do. Anybody can do bronchoscopy, can do that, and it's easy to get the stones out. Then you can dilate the common duct, or you can put a stent in if you need to.
Yeah. So it's a lot to unpack there, but start with the actual exploration of the common duct. Let's assume we're doing an open chole, and you have done a cholangiogram. You found a stone. So what did you use to shoot the cholangiogram? So this part of the podcast. Assume you're talking to a resident that's never seen it, or to a young general surgeon like myself that's never seen exactly this, but they kind of know what you're talking about. So what kind of catheter do you put into the duct, and how do you secure it, and how do you shoot that cholangiogram?
You mean under open?
Yeah, sure.
You can just they make a catheter, a cholangiocath catheter, or multiple ones that are manufactured, and you can just put it in the cystic duct, put a hemoclip over it, and shoot your X-ray. Okay. Now, when we started off, we didn't have the X-ray machines where you could look at the image right away, and so we had to do films that the tech would have to take it down to X-ray, develop it, and then bring it back, and we'd see if there's a stone or not. But now, of course, we have the fluoro where we can just do it right away, and then we can actually do fluoro while we're doing the procedure, taking the stone out, and it makes it a lot easier.
Yeah, so that's great. So then you do that, you identify a stone, and these patients, maybe they didn't have, presumably these patients you didn't necessarily know about, but obviously if somebody has elevated bilirubin, particularly direct bilirubin, bile duct is dilated, then you're suspicious for this. And nowadays, when did MRCP come along?
You mean ERCP?
MRCP. So if I have a patient now that I'm suspicious for a common bile duct stone because they have an elevated bilirubin, or they have a dilated bile duct on either ultrasound or CT, then I'll do an MRCP,
right?
Which is really, sometimes you can pick it up on a CT scan or an ultrasound. But if they're both negative, but I'm suspicious, I'll do an MRCP to try and confirm that duct is that stone is in the duct. But it really wasn't an option for the majority of your career, right?
That's correct. Well, we had it available probably as soon as we got MRI, and I think that was around 2005 or something like that.
Okay. So anyway, we have this obvious stone on cholangiogram. And so now what's your next step to do the common bile duct exploration?
Well, just make a longitudinal incision. And then first, you could irrigate it out. And then after you irrigate it out, you can take your choledocoscope and put it down through the common duct. I always look proximally and distally. And if the scope went right down into the duodenum, then it means you probably washed it free. If there's a stone there, you try to push it through. Now, when I was doing laparoscopic cholecystectomy, I always tried to push the stone through first with irrigation and then with a catheter. And then we would try then we'd go ahead and do a choledocoscopy through the cystic duct and then take a basket and remove it. And if that didn't work, then we would try to crush the stone with a basket. I even used a laser several occasions to crush up the stone and then irrigate it out and push it on through. We'd always do a completion X-ray to make sure that there is no stones left in. If we're doing it laparoscopically, then we wouldn't have to put a T-tube in. We just clamp the cystic duct and we would be finished. If we were doing it openly, obviously, after we got all the stones out, we put a T-tube in and put a drain in, and then after about 6 weeks to do a T-tube cholangiogram. If it was okay, then remove it. If it's not okay, then we do a choledocoscopy percutaneously.
Okay. So tell me the incision that you made, that longitudinal incision on the common bile duct that you're making, I assume, anteriorly, avoiding 3 and 9 o'clock where the blood vessels come in.
Right.
Where is that located relative to the cystic duct?
I would usually do it right where the cystic duct was.
Okay.
Unless the cystic duct was in an abnormal position.
Okay. And then your choledocoscope, which is essentially like a bronchoscope. Did you actually have a choledocoscope or did you use a ureteroscope?
You can use a ureteroscope. We actually had a choledocoscope.
Okay.
But you can use either one.
Okay. And then so you're using that with a pressure bag of irrigation?
Yes.
As you scope it. And did you ever infuse glucagon to try and relax the sphincter?
Frequently.
You use 1 milligram?
Yes.
Of glucagon, yeah. And then usually let it circulate, try to flush it through.
Right.
And you scoped proximally and distally with your essentially choledocoscope functions like a bronchoscope, like you said, and it's got the continuous flow irrigation so you can see the inside of the duct. So this is a very tiny scope. And then you've got a working channel that you can run a basket down like a nitinol basket that's just got 4 wires, and you could grab a stone and pull it out or go ahead and push it on through. So that's all making sense to me. And then every time you did that, you always put a T-tube. Is that right?
If it were open.
If it were open, yeah.
Obviously not if it were a laparoscopic.
What if you had a chronically obstructed duct and your duct was really big, like 1.5 centimeter duct? Would you ever stitch that up primarily and just leave it, or you still always left the T-tube?
I always put a T-tube in, but there are people who would repair it, sew it up.
Yeah. So I had a case like that in residency that we had about 1.8 centimeter duct, but we did it all laparoscopic, but then stitched it up laparoscopic as well. So that was a cool one. Okay, very good. So then move to the laparoscopic area. I can talk about what I do, which sounds very similar to what you were describing.
And let me just say one thing. The reason we started doing that is we didn't have ERCP available, and it made it easy for us to do complex choledochal surgery, and we didn't have to do ERCP. And there are actually some people who think that this procedure is just as safe, if not safer, than doing ERCP. You avoid the problem of severe pancreatitis, and you've all seen severe pancreatitis from ERCP.
Yeah, and I'm one of those people. So that might be a minority, but I feel actually quite strongly about that. And it's definitely better for the patient. I would say the patients never really understand what you did in the first place. I try to draw diagrams and explain, and they're just like, yeah, well, Dr. Lehman took my gallbladder out, but that's okay.
Well, I videoed all my cholecystectomies. I gave a copy to the patient. There were some people who felt that was not a good idea, that it might lead to a malpractice suit. I don't agree with that. The patients loved it. They'd go home and watch the video, and they'd come back in the office post-op, and they say, oh, man, that was pretty neat.
That's awesome.
And I thought that was a lot of fun and a great marketing, too.
Yeah, right. So, or how were you recording it when you first started doing that? Were you not doing it until it was digital?
That's correct.
Okay, so there were discs.
The first cameras were terrible.
Okay.
You could barely see. It's amazing. It's amazing we didn't have more problems. Mm-hmm. And people talk about injury to the common ducts. I think one of the reasons in the early part of laparoscopic cholecystectomy was because our equipment wasn't very good. Now, it's interesting how I started doing laparoscopic surgery. I was at the SAGES meeting in September of 89, and there was, I can't remember his name, but there was a gentleman there, a doctor from France, who was doing laparoscopic cholecystectomy. And at that time, SAGES was an endoscopy club, and very few people were paying attention to him. But within just a few months, Eddie Reddick started teaching a course on laparoscopic cholecystectomy in Nashville, and it just like exploded the number of people who were doing it. I had scheduled a class with him in June of 1990, and they called me up and said, we got an opening in January. Why don't you come on down? And I said, oh, I'm too busy. And I put it off. In those 6 months, I was already behind. We started doing it in July of 1990. I had a gentleman who had just finished his residency in Louisville, and we started doing them together. And we always did them together to try to be safe. And that's how we got started. But I made a mistake, and I should have gone down to Nashville with Eddie Reddick in January. It was interesting that Eddie Reddick gave all his patients a copy of the video. And not only did he have a video, but he had audio. He actually talked to the patient while he was doing the procedure and told him what he was doing.
Wow. That's insane. It's just we stand on the shoulders of giants, and that's what it's hard to even fathom what where we've been. Another time, maybe when we record another time, we'll talk about Jane Todd Crawford and that story. But I'd like to wrap up the laparoscopic portion of the common bile duct exploration, because you said you put the choledocoscope in the cystic duct So laparoscopically, you never made an incision on the common bile duct, right?
I never did. There are people who did that. One of my partners started doing that if he couldn't get it through the cystic duct. Now, we'd usually have to dilate the cystic duct with a balloon.
Sure.
Sometimes it would go through, but sometimes it wouldn't, so we would dilate it, and then we would thread it down into the duodenum.
So if somebody wants to be successful with this, my main tip, so I do this, but I'm selective. And I've had good success with it in terms of clearing the duct and avoiding ERCP, avoiding then a transfer for my patients from my critical access hospital to a referral center, which can be a big hassle. There's a lot of ERCP availability issues. And so I can dilate the duct, but I don't even try if it's a tiny, tortuous duct. Now, fortunately, most of the people with choledocholithiasis have anatomy that is a short, fat, cystic duct. So if you can see a nice, fat, cystic duct short, those are the ones where the tiny stones can slip through and then go into the common bile duct anyway, or if they've been partially or chronically obstructed, then it will create the anatomy like that that's favorable. And so then I do a transcystic laparoscopic common bile duct exploration. I put an extra 5 millimeter port in the right upper quadrant. I bring my choledocoscope through there, which I use the disposable ureteroscope, that LithoView scope. Not sure who makes that, but that's what it's called. And I stick it through there. And the nice thing about that is the ureteroscopes are really expensive. The permanent ones, like $100,000 piece of equipment. And if I break it, I feel bad. So those disposable ones, I can really crank on them, and if I need to. And anyway, pass it in, pressure bag, and then this is after I've shot a cholangiogram, and then go down distally, find the stone, try to push it down, same deal, and then if I can't, basket it and pull it back out. And I pull it completely out through the cystic duct into the abdomen and out through that 5 millimeter port. Or if it's too big to do that, then I'll just drop it there and then grasp it and take it out my 10 millimeter port. And I've had great success with that. And again, like I said, the patients don't really know what you're letting them avoid, which is the ERCP and the transfer and all the hassle of all that. But they generally still are thankful. And then I usually keep them. And then get LFTs in the morning and then let them go home the next day. But that's been a technique that works for me. I think that it is something that should be continued to be talked about, especially in rural surgery circles where we don't have ERCP, because I think you would really do your patients a service if you offered that. So thank you for your time talking about that. I have another segment of the show, which I'd like to transition to, and that's called the Financial Corner. Do you have, and I didn't ask you this ahead of time, a money tip for maybe the resident or budding junior attending that you could just share things that worked for you or things you wish you did, something like that?
Well, things have changed radically since I started in practice. Just to give you an example, I started practicing in 1978, and our open cholecystectomy, we got paid like $1,400 or $1,500, and now I think most people get paid between $500 and $600 doing a laparoscopic cholecystectomy. And this is not counting for inflation. And all we had to do is do the case. We'd send the bill in and we got paid. There was none of this hassle back and forth, and there was no pre-authorizations or any of those things. I know very few surgeons who are in solo practice. Almost everyone that I know in Kentucky are working for some healthcare system or for the hospital. For someone who's finishing a residency, I would suggest to them that they probably will have to go and work for a hospital. I would suggest that they not go into solo practice, that they work with at least one partner so that they're not totally destroyed. I worked for a year in solo practice with no backup or coverage, and I don't suggest you do that now. The most important thing that I did financially was that my first partner and we started a defined benefit retirement plan. And so we were able to contribute a lot of money into a retirement plan, and that accumulated over a long period of time tax-free. Now, the disadvantage of that is you have to pay all your employees the equal amount percentage-wise, but in the long term, it really, really pays off. So when you start off from day one, think about your retirement, and if you don't, you could end up retiring and then not have enough money that you need to live the way you want.
Yeah. Oh, those are great tips. I really appreciate it. The other thing that crossed my mind on the laparoscopic exploration of the common bile duct, as you know, your 47562, your 47563, which is your lap chole with your IOC, and then 47564, which is your CPT code for your laparoscopic common bile duct exploration and the lap chole together. If you don't know those, probably do know those. What I didn't realize until like 6 months ago was there's actually a code for the choledocoscopy, and I was not using it for several years, so there's a lost potential. But look up the code for the choledocoscopy and make sure you use it if you do. Obviously, choledocoscopy, you want to make your coding as accurate as possible. The question that crossed my mind when I was thinking about that CPT coding was when you started practice, there was no such thing as CPT, right?
That's correct.
So that's just hard to believe. It's all usual and customary. And then CPT rolls out, and the codes really allow them to identify and tweak things. And I don't know, it's just a different animal. And I wonder where we'll be at 25 years from now, because it's probably going to look just as different as it did 25 years ago. But anyway, I appreciate those tips.
So, well, I hated coding, and in the part of my practice, one of the surgeons started doing most of the coding for us, and then she taught our future office manager to do it, and so I stopped doing coding completely, and they did it all for me. Most hospitals now will have coders. I think at the hospital that I practice in, they have people who do all the coding. I have a friend who works for the University of Kentucky, and he's a retired surgeon, and he is involved in the finance there and the coding, and he tells me that probably the doctors and surgeons shouldn't be doing coding because it's become so complicated. That's another big issue in medicine. It's getting more complicated, and it'll eventually have to be solved.
I think you need to be aware, though, of at least coding. Like, you need a book, okay? And you need to look at it for the things that you do routinely, because it's going to simplify, if anything, it's going to simplify your life for coding queries, because you're going to write the right things in your note that they're looking for. Because otherwise, they're going to be asking you questions. You're going to be irritated. But I think, you're also going to be paid based on a lot of that. And so you just need to understand, at least a little bit. I just think of all my codes, and I write those on my charge sheet, and I give them to the office, and then the coder confirms all of them and everything. But that's good.
I think you have to know some of that, and it's related to reimbursement, unfortunately.
Yep.
And unfortunately, it's become way too complicated.
So I have a section of the show called Classic Rural Surgery. This is where I ask you a question. Tell me about a story which is just so classic rural surgery, if you will. And things that come to mind is, just something you would see in a small town that you would never see in the city. Is there anything that sort of comes to mind when you think of that particular patient story?
Well, what comes to mind are things that a general surgeon would never see in the city, but you would see in a rural area. For example, tubal pregnancy. We would get called all the time for tubal pregnancies. You had to have a knowledge, particularly in the beginning when I started practicing, of gynecology. When I started practice, we did a lot of gynecology. We eventually got a gynecologist, and he and I worked together very closely, and we did a lot of hysterectomies. And then we had a urologist who was interested in pelvic relaxation and third-degree cystocils, etc. And he and I used to work together frequently for that. For example, I used to do the vaginal hysterectomy. He do the anterior repair or bladder suspension, and I do the posterior repair. And we did a lot of that, and we had good success. And we knew we had good success because we're in a small town and everybody knew what was going on. Your peer review in a small town is the community. It's not some guy sitting off in a big city who's looking at your charge.
Yeah, that's very useful, and that's what I'm doing. So, I'm gonna, and there's no OBGYN in any of the places that I'm currently working, all critical access hospitals. The other week I did a paratubal cyst that was huge, and it was about this big. Did it laparoscopic. CT shows it. It says it's probably coming from the tube, not the ovary even. So that's a pretty simple decision. And she's in a lot of pain. She had peritonitis. I went in. It was really angry, red, and inflamed. I just decompressed it with a needle, chased it down to a stalk. Sure enough, it was torsed there. Cut that with a ligature. It's a 12-minute case. Pulled the cyst out, sent it in. I just saw her back on Thursday, and she's just perfectly good. So this is not something that a general surgeon needs to be intimidated by. You probably need to have a resource, somebody that you can kind of bounce things off of. But yeah, GYN, there's a lot of things that show up that, totally could be handled in a small town.
Now, if you're in a residency and you want to go into rural surgery, you need to kind of plan accordingly. At least in your last year or two of residency, you need to plan on where you're going. And that's very important. Are you going to have to be able to do C-sections? Are you going to have to be able to do gynecology, at least emergency gynecological procedures? And so if you are, then you need to train to do that. I was very fortunate at the University of Louisville. They allowed me to take rotations on non-general surgical services. Like, for example, I spent 3 months on OBGYN, on GYN. It was not OB. And then I spent about 3 months on orthopedics. So I did all that when I started off in practice and can continue to do it for quite a long time.
Yeah, that's a good tip. You basically, and you stayed a little later after residency, right, to do a little bit more?
Yeah, I spent 3 extra months. I did 2 months on endoscopy. By the way, I don't think you can do rural surgery without doing endoscopy. I mean, Randy has got somebody that's doing them for him, but most rural surgery practices, at least a third of your practice is going to be endoscopy. Now, that does not include ERCP, but it includes colonoscopies and EGDs. And we did advanced endoscopies. I mean, we did not hesitate to dilate the distal esophagus for strictures. It was very routine to find the patient who had food stuck in their distal esophagus. We would routinely remove those. So endoscopy is extremely important. I also did 2 extra months in orthopedics. When I finished, I did fractured hips and I did closed reductions. Complicated orthopedics will refer usually to the university. And then I did a couple of months on thoracic surgery. And one of the thoracic surgeons was interested in putting in pacemakers. That was just the beginning of pacemakers. So we started doing that. And so I started doing pacemakers in my hospital and did pacemakers for many, many years. And one of my partners I was just talking to the other day, I taught him how to do pacemakers. He's doing probably 60 a year, and it's a valuable service and can help a lot of people. And they don't have to go out of town for that. Now, we're not doing defibrillators or things like that, and we do pacemakers and consultations with cardiologists. I never did them without a cardiology consult, unless it was an emergency. Somebody had a severe bradycardia, like a heart rate in the 20s, etc. But it's it can be easy to do, but it's also important that you have good representatives. Whoever's coming down for the pacemaker company, you need to be able to work with them, and they were very, very helpful for me during my career.
Yeah, I forgot about pacemakers. You did a pacemaker when I was down here on rotation as a fourth-year medical student. That's not something that I'm doing in my practice right now, but something to think about. So, and the last segment of the show is really resources for the busy rural surgeon. And I think you did a great job talking about things you want to look for in training, say if you are a resident, ways that you could pick up, things that will be, you're looking for, how can I provide the most value to my community so that people don't have to leave town and they can get care close to home for all the right reasons, meaning you keep your hospital viable, you keep jobs in the community, you want to do things that are safe and just as good as can be done out in the city. And so with your resource limitations, what can you do? And a lot of times that's some subspecialty things, like I do carpal tunnels and hysterectomies and some GYN stuff. Those are simple cases that the patients generally do really well. They're great cases to do for rural surgery. So thanks for sharing that. But I also just want resources for the busy rural surgeon. And I know you're an advocate for the American College of Surgeons, and you've also talked about having a network outside of your small town. So maybe comment on both of those or any other things that you think a rural surgeon just really needs.
Well, I think you should try to be very active with American College of Surgeons. I think they do an outstanding job in training and in continuing medical education. I don't think there's any organization that does a better job. And they've really, really done a wonderful job with that. Not only with the conference they have every fall, but also with other educational things, for example, CSAP. And I also think it's very important that you network with a regional medical center. I networked with the University of Louisville. I was on the clinical staff there. We had a working relationship. I knew everyone. They knew me. We worked back and forth. And if I sent them a patient, they would communicate with me. Sometimes they would send them back and I'd see them post-op. If I had a difficult patient that I didn't feel comfortable with, I could call them up and we could get the patient seen right away. And so we work together very, very nicely, and I think that's extremely important. Just to call up and ask somebody's opinion about something is really important. Don't try to do everything on your own. Get other people's opinion, particularly if you're by yourself or your partner's out of town, etc.
Yeah, it's who's your backup. So would you be calling general surgeons or specialists?
Well, it depends on the problem. For example, I had a very good relationship with a vascular surgeon in Louisville who we had trained together. He was an intern when I was the chief resident. We maintained our friendship, and he did a fellowship in vascular surgery. And so I also did wound care, particularly a lot of wound care in the latter part of my practice. And we see a lot of vascular problems. I became very good at working those patients up. If they had a vascular problem, I would send them to him, and we communicate very, very well. And so that really made a difference. It makes a difference if you call somebody and on their cell phone and they call you right back. Or if you have a post-op patient that he's seen and you call him, say, hey, listen, this patient's got this problem, and they take care of it right away. That's a benefit to them and to you.
Yeah, I have the same deal. So I've called general surgeons for problems. I have also called, I have a colorectal surgeon. So mostly I don't do rectal surgery, but I do still colon cancer. I think it's really good if you can have routinely things that you're sending them, and then you can, I can also ask questions about the things that I would routinely do. And then vascular as well. I also am involved in supervising a wound care clinic, and I went to meet the vascular surgeon that I was working with most at the nearest referral center, and I took my nurse practitioner down. Me and her met, him and his nurse practitioner, and we talked about, how do you want us to work up vascular disease? Where do you want the duplex? Or you want the CTA on everybody? And so we've kind of worked through that, and then I do the things, the wound care, the varicose veins, things like that in my practice, and then he does the things where you need too many stents and all of the equipment, and ideally sort of a hybrid room and everything that should go to a referral center. And that's what we send down. So, and then the bypasses and whatnot. So,
yeah, but it's very important to communicate with that vascular surgeon. Let's say you got a patient that's having a rest pain, and the patient's got diabetes and it's got some renal failure. Do you really want to do a CTA on that patient, or do you want just to send them directly to the vascular surgeon and let them do an ultrasound? And they might want to do an angiogram on the table in the hybrid room, and so they don't have to. This patient doesn't have to have a double dose of IVP dye.
Yep.
Now, another thing I think is really important if you're a resident planning on going into rural surgery, you've got to know how to take care of rectal patients and problems. For example, anal fissures, fistulas, perirectal abscesses. They can easily be treated, but it's amazing. A lot of general surgery residents are not trained on how to take care of those. You need to make sure that you learn how to do that. You need to learn how to take care of hemorrhoids. You need to know which hemorrhoids to operate on. I did a lot of banding of hemorrhoids in the office, and you need to know how to take care of a thrombosed hemorrhoid. I used to drain a lot of thrombosed hemorrhoids in the office. These are things that a lot of general surgery residents don't learn how to do unless you make a special effort to learn how to do it.
Yeah, and it's not that difficult. I mean, but you can make friends with a colorectal surgeon, obviously, in your training, and then just sit down and do oral boards a couple times on, everything's hemorrhoids. Obviously, it comes to you billed as hemorrhoids, but sometimes it's fistula, abscess, fissure. Sometimes it is hemorrhoids. Sometimes it's prolapse. Sometimes it's rectal cancer. Sometimes it's fungating.
Tumor.
Tumor.
Nobody's done a rectal exam on.
Right. So you never know. They're all billed as hemorrhoids, but you need to basically get yourself ready for that. Do you want to do a bonus how I do it section on that?
A bonus?
Or is it too late?
Well, you were talking about rectal prolapse. I used to do those too, and I had great success with doing those. All
right, so let's
see a lot of them.
Let's do bonus how I do it, but rapid fire.
Oh, okay.
So, all right, we'll do every perianal. I say every, but probably very close to every perianal problem. Okay, let's start with hemorrhoids. So you have internal hemorrhoids that are prolapsing or bleeding, and there's no external hemorrhoids. What do you do?
I usually treat those conservatively with annual suppositories and sitz baths. Most of them get well doing that. If they don't get well, then you can resort to hemorrhoidectomy. At the end of my career, I changed the way I did hemorrhoidectomies. I used the the ultra. What's that? There's
Harmonic.
Harmonic. I use the harmonic, and it does very, very good. Now, one of the things I want to tell you is that general surgeons, I think most surgeons don't understand how to use local anesthesia. I learned to do that when I was a resident down at the Trover Clinic in Madisonville, Kentucky. And they did all, excuse me, they did all their hernias under local. And when Marcaine came around, if you mixed Silocaine with Marcaine, and you can get very good anesthesia. It will last 6 to 8 hours. And if you stop that immediate throbbing pain, you can get by with a lot of surgery, and you don't have to give as much narcotics. We talk about the overuse of narcotics. Well, if you use local anesthesia, you can really reduce the amount of narcotics you have to use. I never did an abdominal surgery without putting Marcaine and Silocaine in the incision before I started. And it's very, very important to do that preemptively, to start the operation with Marcaine and Silocaine rather than putting in it at the end. And now with the transabdominal Marcaine that anesthesia is using, it even makes it more beneficial, and patients need less narcotics.
Yeah, you're talking about a tap block. So how are we doing with our rapid fire perianal condition here? Not very good. For me, internal hemorrhoids require banding, and external hemorrhoids.
I forgot that. Banding works.
And external hemorrhoids are where I do a hemorrhoidectomy.
You can't band external hemorrhoids.
So if they're below the dentate line, then they get.
You can do that in the office
sensation.
too.
Right.
I do it in the office all the time.
Okay. Okay, and when you do the hemorrhoidectomy with the harmonic, do you close the wound?
You don't have to.
Yeah, I stopped closing the wound.
Yeah, you don't have to.
Yeah.
It seals on its own.
Yeah.
If it comes apart, it'll still heal.
Yep.
A lot of people do hemorrhoidectomies, they never closed them. They do it open.
Okay, very good. So there's hemorrhoidectomy in a nutshell. Of course, try and fiber first. Let's talk about you do your exam in the office or under anesthesia, and you see a posterior midline fissure, and there's really no hemorrhoids. What do you do?
Okay, I wouldn't do anything if I found it under anesthesia, except maybe anoscope a patient. But if I found it in the office, then I would treat those patients with Syspas, suppositories, and nitroglycerin ointment. Mm-hmm. And then if it doesn't heal, then you do a lateral internal sphincterotomy. And I was reluctant to do that at first, but I found out that lateral internal sphincterotomies really work. Patients get pain relief almost instantly. You still want to use a lot of Marcaine with those patients. And if somebody comes into your office complaining of severe rectal pain, it's usually an anal fissure.
Yep, I agree. Talking about local anesthesia, so every single perianal case that I do, I use Exparel field block. Did you use Exparel at your career at all?
I did occasionally, but I think it's a great idea.
So that's liposomal bupivacaine. I get a lot of...
Yeah, well, I'm talking about long-acting local anesthesia.
Right, but your Marcaine's lasting 6 to 8 hours, but your liposomal bupivacaine, that lasts about 48 to 72 hours.
Yeah, I think that's a great idea. I did not use much of that, but I think it's something you should know about and use.
And I think it is going off of the trademark, so becoming generic and possibly becoming more affordable.
That was one of the reasons we didn't use it a lot.
Yeah, so that's good. Okay, and then let's talk about, we'll talk about abscess first, I guess. So how's the abscess? How do you know the patient has an abscess? Is it by a CT scan? I know, it's tongue-in-cheek. Tell them. I mean, right.
You don't need a CT scan to determine you got a perirectal abscess. But I used to see people all the time that had a CT scan to make a diagnosis of perirectal abscess. Even patients that were very obvious they had a perirectal abscess, and somebody in the emergency room had ordered a CT scan. You don't need to do that.
So what do? Make an incision over the maximum area of fluctuance, just like any abscess?
And you obviously you got to know where it is. If you don't want to cut through the internal and external sphincters both. You can cut through the internal, but if you cut through both, then you might have a rectal incontinence. If that's the case, put a ceton in it.
Yeah. So I was always told to make the incision as close to the anal verge as possible to shorten a fistula should it happen. Agree with that?
Yes.
Okay. And so nowadays, I don't think ceton at the time of drainage is really commonly needed or done because most of them will heal on their own without becoming a fistula. So ceton's still a useful.
But I'm just talking about if you've got an extensive abscess,
right,
and that you have to cut through the internal and external sphincters.
Yeah, okay. Or like a horseshoe abscess. CT still, don't be scared of it. Obviously, I order a lot of CT scans, probably more than he would want, but sometimes it serves as a roadmap for me for surgery, and then I can see if there's horseshoe component or whatever to these abscesses. But I agree, if there's physical exam finding of an abscess, that patient is going to be relieved if you can just drain it. So then I tell my patients that 1/3 of all abscesses after you drain them turn into a fistula. Do you feel like that's a good number to throw out?
I think it's a little high, but I don't know the data on that.
Basically, there's some of them are going to turn into a fistula that's going to need to be treated as well. So now you've got somebody that's got maybe they had an abscess drained and then they've got some drainage long term, like after 6 to 8 weeks, and you think they might have a fistula. What's the best way to diagnose a fistula? MRI?
I just take a probe in the office and numb it up a little bit and probe it and see where it goes. Sometimes it'll come right through a hole in a mucosa, but a lot of times it won't, but you can usually tell where it's draining. And then you do a fistulotomy. Again, depending on where that goes, it goes up high in the rectum and to the sphincters, then you want to, I usually put in a ceton, but I didn't have to do that very often. And cetons are difficult to manage. It causes a lot of pain, and particularly when you tighten it and they come in the office every week.
So you're using the ceton to cut through.
Right.
And that is a silk stitch?
You can use that. I use a small Penrose drain.
Okay, and just a real tight Penrose drain will come all the way through?
Yeah, but you have to tighten it every week or two.
Yeah. So I
would pull up the Penrose drain and then I'd have a nurse hold the Penrose drain and tie a silk suture around it.
Okay. So I find cetons really useful when there's still some remaining abscess and you need it to collapse into a tiny tract. And then, you can use I would say using a 2.0 silk for my cutting ceton would probably be the way to go. But there's also a lift procedure, plugs kind of in and out of favor. But you can obviously read more about that, but beware of fistula.
You use plugs?
I don't use plugs, no.
I've never used them very
There's
much.
people testing out stem cell injections, things like this.
Stem cell?
Yeah, it doesn't work too well yet. But
isn't that kind of expensive to use stem cell?
Yeah, that's why it's experimental. All right, so the other thing would be rectal prolapse. So how do you treat rectal prolapse? You talked about Dr. Altmaier already today.
Yeah, I usually did the Altmaier procedure, and it works very well. But those are very rare. I may want to do 1 or 2 of those a year.
And how about ever do a sigmoid colectomy with rectopexy?
Yes.
So who would you decide an Altmaier versus sigmoid colectomy with rectopexy?
Well, it depends. If you just had mucosal prolapse, then you just one of the things that I would do is band that, rubber band it. And if they were an elderly patient, a poor wrist patient, and they had the whole mucosa, maybe only 4 or 5 centimeters at the most, you could do an Altmaier procedure. But if they were young and in good health, you can do a sigmoid resection and a rectopexy. But most of the patients I saw with that problem were elderly and you didn't really want to do a major operation.
Yeah, so I've seen both, and it's the same deal. So you have 40, 50-year-old woman, I mean, that's a laparoscopic sigmoidectomy with rectopexy in my hands. And then nursing home, 85-year-old patient. We can even do an Altmaier under spinal.
Sure, I did that many times.
Yeah.
Well, not many times, maybe one or two a year.
Right.
They're not very common.
Right.
But they're going to become more common because of the elderly population, which is increasing.
Right. But they're not having as many kids, so maybe, who knows? We'll see how it affects the prolapse.
Well, I think constipation has a lot to do with rectal prolapse.
Sure. How about anal condyloma?
Well, first you want to make sure they're condyloma, biopsy them. Mm-hmm. And then I just took a bovie and coagulate them.
Yeah.
Some people use lasers, but that's an expensive way to take care of a benign problem.
Yeah, and you may have to come back and clean it up.
Yes, absolutely.
Depends on
I always tell the patient they'll come back.
Mm-hmm. That might also come down with the Gardasil vaccine. So.
Well, absolutely, but unfortunately, not too many people are getting the Gardasil vaccine. The incidence of cervical cancer is not decreasing as much as we had hoped, although it's much better than it used to be. And another thing that I did that I think has lost failure, I did not hesitate to do pelvic exams in the office. And I did pap smears. I think if you're going to operate on somebody, you need to know that their uterus and ovaries and everything's okay and their rectum's okay before you start operating on them. You don't want to be in an operation and we're going to take their gallbladder out, and then there's this problem in the uterus or the ovary, and you don't have permission to do that, and so you have to do an operation, and then they have to come back for a second operation. I don't think that's a good idea. I know physical examination is kind of fallen out of failure, but I still think it's important to do. And I know something else has fallen out of failure is doing a rectal and pelvic examination on anesthesia. It's that the trend is now you got to have permission to do that. I used to do it all the time, and I never got specific permission. But I think that's a mistake, but something we have to live with now. And as a general surgeon, you should be able to do a pelvic exam, and you should be able to know what's going on.
I would agree with that. Yep. Okay. Well, beautiful. Did I miss anything for perianal conditions? I was doing that all from memory, so we might have to put it as a bonus episode. I think we did pretty good. Covered it pretty well. Thank you so much for this time. I really appreciate it. Thank you for also everything. We met a decade ago, this coming fall. And so just thanks for all the mentorship over the last decade. The main message, honestly, if there was any from this episode is find yourself a mentor or a set of mentors, people that you know will not throw you under the bus, that you can call and you can ask stupid questions, and they will tell you just the answer without making you feel stupid. I had a benefit in my training to go to Honduras on a mission trip with Dr. Shively. After I did early fourth year rotation with them, then I went as a late fourth year to Honduras. And then I kept going through residency to Guaymaca, Honduras. And it's really cool because now I'm going every year as a attending staff, volunteer, and running my own room. But all of these people on this team and at the location kind of watched me progress through surgical training, and to come back and do 40 cases in a week just with the same guy and then make progress. It really, I think, enhanced my training, and there's more trust the more you have a longitudinal relationship with someone. And so just look for these opportunities. I did that on my vacation, right? So however much vacation you get as a resident, and I went and operated on that time. That, first off, it was still a blast, and it was helping other people. But it really helped me too to become a more confident and capable surgeon. And so I just owe you so much. So not just today in this episode and pulling me on the water skis, but just for everything. And you've just become one of my best friends. And I just really appreciate you. And you're not allowed to ever die, so don't do that. And you keep coming back and be another guest episode, please.
Okay. I would strongly recommend, as a medical student and a resident, to go on medical missions.
Yeah.
You learn so much. You learn that you can be a very good surgeon without CAT scans. And you learn to do physical examination, and you learn how to do open hernias. And this is an extremely important learning curve, and it's something really important to rural surgeons. Not only is it important for your profession, but it's also lots of fun. And you go somewhere with people in drastic need and who cannot get this service unless you're there, and it makes you feel better. It makes you realize why you really went into surgery in the first place.
Yeah, thank you. The other thing I'd like to, is there anything that maybe my audience, that you would like to tell them if you want them to get in touch with you? I know you have a podcast of your own. We can put the link to that podcast in our show notes. Just tell us really briefly what that's about.
It's about the U.S. healthcare system. Retired surgical oncologist at the University of Louisville and I have been doing this for about 3 years. And we've gotten into various subjects about the U.S. healthcare system, the problems that we have, the cost of the U.S. healthcare system, and some of the waste in our system, things that we do that no one else does. Just an example, for-profit health insurance companies, equity companies involved in healthcare, the cost of pharmaceuticals. We're one of the few countries in the world that are allowed to advertise those type of things that we've spent a lot of time on. And we've interviewed all types of people. We've had interviews with trauma surgeons, surgical oncologists, and it's been very exciting, and I've learned quite a bit.
Yeah, so you can check that out. That's in the show notes. I think that's a wrap for us, you guys. Thank you very much for joining us. Don't forget to like and subscribe. Share with all your rural surgery friends. Join us and interact with us on our Facebook page. It's been a pleasure. I'll see you next time. Thank you.